again, evaluation of stones is important because stone analysis, as we talked in the previous slide, may give you some clues how to treat it. Kidney, ureter, bladder X-ray, intravenous pyelogram, and CT scan is one of the options, and some of the options you can use. But again, also clinical presentation maybe. And one of your clinical clues is the colicky pain, again, flank colicky pain. Then maybe you need to do some imaging, and imaging certainly will be KUB versus IVP versus CT scan. And usually in modern emergency rooms, sometimes they would opt out for CT scanning, while probably plain X-ray with KUB will be for more or less diagnostic for this. Stone analysis again tells you how to treat it, and again, if it's for instance uric acid stone, you can just increase that pH and get rid of the stone. But stone removal also may be done by percutaneous nephrolithotomy versus open surgery and surgical removal and trying to get that huge stone out of the kidney. But nephrolithotomy should be sufficient. Most stones will respond to that, and it's possible to remove it. Neurogenic bladder is a complicated and complex and sometimes very emergent condition which occurs when some type of neuro disorders, some type of disorder that affects bladder innervation is occurring. So bladder innervation destruction or obstruction, or not obstruction but interruption of bladder innervations may cause neurogenic bladder. So what can cause that? It can be secondary to brain or spinal cord injury, neurosystem tumors, brain or spinal cord infection, even dementia, Parkinson's disease, spina bifida, stroke, multiple sclerosis. There are many other things such as alcoholism, lupus, metal poisoning, herpes zoster, and certainly medications can cause this. But again, neurogenic bladder, when we're trying to generalize this, it's condition that most of the time in acute setting can be related to trauma and spinal cord trauma or brain injury trauma. And I remember from my clinical practice in the hospital when I was working as a charge nurse, and one of my nurses accepted the patient from night shift who was admitted with trauma, spinal cord trauma. Unfortunately, during the whole night shift, urinary function hasn't been assessed, and this is really one of the things that needs to be done in acute setting, certainly for everyone. But patient didn't urinate over the entire course of stays, approximately 11 hours, and because of spinal cord injury, he didn't really felt the urge for one or the other reason. But my nurse at day shift was very good, and she basically obtained the orders to catheterize and relieve. And I remember it was approximately 3,500 milliliters, like more than 3-liter Coke bottle came out from that guy. So certainly this is one of the neurogenic bladder instances when the function was affected secondary to spinal cord or brain trauma. other options, other sources in acute setting you may not face, because most of the time it's something chronic, something that really didn't happen overnight. Obstruction can cause this, and lower bladder wall compliance also may cause it. So what are the manifestations? Manifestations can be urinary retention and hesitancy on one hand, like in the case I just described, versus frequency and urgency. And basically it's underactive or overactive, and both cases are neurogenic, the source. How to diagnose neurogenic bladder? You need to, of course, do history, physical examination. Sometime even patient in outpatient setting will be asked to keep urination diary. I remember from my GI days, we would ask the patient keep bowel movement diary, but urology practices ask the patient to keep bladder diary. Urinalysis, culture, sensitivity, cystoscopy, imaging procedures, MRI. Treatment, again, this is one of those conditions that depends on the source, treating the source. So most of the time, if you treat the source, this will resolve. Urinary tract infection are one of the most common conditions you encounter in primary care, and it's inflammation of the urinary epithelium when the epithelium is attacked by bacteria or other pathogen, basically within urinary tract. Complicated versus uncomplicated. Complicated UTI, it's recurrent UTI that usually do not or responds very vaguely to treatment, while uncomplicated, it's rather sporadic and responds to treatment. UTI, complicated and persistence, very similar, while complicated may, of course, the tract infection can from lower urinary tract can travel to upper and even impair the renal function. So depending on the classification of the UTI, the duration of the treatment can be different. Uncomplicated UTI occurs fairly seldom, and the treatment should be short and patient will be responsive, while with treating complicated or persistent, treatment will be longer and it may even result in quite long duration of treatment, 7 to 10 days, versus in uncomplicated UTI there are treatment regimens of 3 days. So depending on the nature of UTI, the treatment duration with antibiotics will increase. Of course, Bactrim is still one of the preferred drugs to treat this, although unfortunately more and more there are cases of sulfa drug allergies, so you may consider switching to other drugs such as Cipro to treat this. But again, if patient doesn't have documented allergy history to Bactrim or to sulfa drugs, you certainly may try that. Or of course the best option is that patient already been treated in the past with sulfa and you have documented no reaction to sulfa, then you can opt for treating with sulfa and get great results with UTI. But sulfa allergy is getting more and more common, so you have to be very careful while prescribing, treating this with sulfa drugs, and history taking you will be I know you all will be taking eventually an assessment course, and history taking in UTI assessment has utmost importance, because it's really part of the history is to take the history of allergies, because you do not really truly, you don't want to give sulfa drug to someone with hypersensitivity history or anaphylaxis to sulfa, which again some patients would not know those fancy words, and they would not say, have you ever had anaphylaxis? I don't know what it is, so I'll say no. So you have to take thorough history, and it will save you lots of pain as well as your patient. Please be very very focused and very attentive to details, taking the history of something this simple as UTI. So when we're talking about simplicity of UTI and fair ease of treatment, of course complicated or persistent needs to be addressed more thoroughly. Maybe some imaging studies needs to be done, but overall UTI is something very simple and responsive to medication. But when we talk about interstitial cystitis, it's rather debilitating and complicated condition that there is really no known cause. Of course, we can look through literature, and there are lots of hypotheses and speculation where this is coming from. However, truly there is no known cause what happened, and it's a painful condition due to inflammation of the wall, of the bladder wall, and it's often misdiagnosed as UTI, unfortunately, and it's often misdiagnosed as a persistent UTI with lots of antibiotics dumped into patient's system, trying to cure this. And actually there were studies done, and it takes approximately, this is really outrageous, but that's the truth, it takes approximately 4 years from the time that patients start having first symptoms to the time of the actual diagnosis. So this condition is most commonly affects people around 30-year-old, 30 to 40, maybe a little older, and also it can happen in younger people. Women are more likely to have interstitial cystitis than men, and it's actually approximately 10 times more likely. Again, demographics, it's really FYI information, but I won't be testing you on these numbers, but it's nice to know for you, and it will help you to understand the disease. But if you cannot memorize numbers, there's no problem here, because there will be no testing, and it really in the big scheme of things won't affect your understanding of the disease. So